receive a token. So we send tokens to all participants. Whenever you receive a token, you'll come under claim tokens to claim it. For example, I'll demonstrate with a token I received for the World Pharmacist Day webinar, which was done in conjunction with GSK. I'll come here to claim token. I'll paste my token here and I will claim points. It will tell me that I've been awarded 1 point. This is the point I've already been awarded. Usually there are some issues that you encounter. It will tell you that that token is invalid or it's expired. It's when you claim the token. Where do you get that? It's when you claim the token under a different event. For example, the same token, if I bring it to another event, it will give me an error. It will say, for example, this one will say the token is invalid or has already expired because it's a token for a different event. Another issue that members complain is that they say I cannot find the event under the claim tokens. That means your subscription was not successful. You either clicked in quick succession or you did not confirm whether the subscription was successful or not. It is important to note that subscribing is very important if you are to get the point. Attending an event without subscribing means the token that will send you will not help. It will not be of benefit to you. So it's always important to subscribe to all the events for CPD to work for you. Panelists for the conference will be receiving two points per presentation, the panelists and abstract presenters, and these will be up before the end of the conference. Thank you very much.
Welcome back, everyone, to the second part of today's session. We're going to go into another abstract presentation by Dr. Anne Mercy Wanjiku, and it will be on retrospective medication use of COVID-19 patients at Kenyatta University Teaching, Referral and Research Hospital. Over to you, Dr. Anne Wanjiku. Karibu. Dr. Anne Wanjiku.
Hello, can you hear me?
Yes, we can hear you.
All right, thank you so much. My name is Dr. Anne Mercy Wanjiku. I am a pharmacist at Kenyatta University Teaching, Research and Referral Hospital, and I'm very delighted to be presenting at this esteemed conference and very humbled that you all joined in. So I'll be presenting on the topic of medication use review of COVID-19 patients at KUTRRH. That's the overview of the presentation. Medication utilization review, also known as drug use evaluation, is a system of continuous, systematic, criteria-based medicine evaluation that ensures the appropriate use of medicines. The concept of MUR is not new. It was first done in Northern Europe and the UK in the 1960s, where it revealed remarkable differences in the sales of antibiotics in 6 European countries. This led to WHO to constitute a drug utilization research group to ensure rational prescribing and appropriate use of medicines. So now with the unprecedented entry of COVID-19 pandemic, a disease that we don't have a lot of knowledge on, and we also don't have an approved treatment regimen, the question begs that what drugs then are our prescribers using in the management of COVID-19? So this study will aim to answer that question by establishing the trends in medication usage for COVID-19 patients at KUTRRH. Next slide, please. All right, so on to methodology. We conducted a retrospective cross-sectional study for all COVID-19 patients who are admitted at KUTRRH between 1st and 20th April 2020. Our sample size was 192 patients. We reviewed their treatment sheets and collected the following data: age, sex, medications used, and comorbidities. The data collected was then recorded in Excel sheets and analyzed using descriptive statistics. So going on to the results, under demographics, we realized that we have more males than females affected or rather infected with COVID-19. We had 64% of the patients admitted being male and 36% of the patients admitted being female. And this is a picture that's also reflected nationally with data from MOH showing that 65% are male and 35% are female. So some reasons have been posted as to why males are being affected more than female. I'd say that mostly there's the factor of lifestyle choices, where more males than females engage in smoking. There's also the fact that males have a high expression of ACE2 receptors, which enables the virus to infect healthy cells. And the women apparently have a robust immune response as a result of genes and sex hormones. Going on now to age distribution, we grouped our patients into 4 groups. The first age group was 0 to 14 years. The second one was 15 to 29 years. The third one was 30 to 59 years. And the last one was patients above 60 years of age. So from the results, it was quite clear that, maybe we can go back to the, yes, thank you. So from the results, we can see that The hardest hit age group was 30 years to 59, where 60% of the patients fell under, followed by the age group of 15 to 29 years, where 31% of the patients fell under. And as you can see, between 15 years and 59 years, we have over 90% of the patients falling under. We also had 6% of the patients being above 60 years of age and 3% being below 14 years of age. So it is quite clear that the youth and the middle-aged are being affected more by COVID-19. And a reason maybe would be because the Kenyan population is majorly youth. A report by Kenya National Bureau of Statistics show that population in urban areas is concentrated between the ages of 20 to 34 years. So maybe this is one of the reasons why we have more of the patients falling under the youth category. Next. When we move on to commonly prescribed medicines, these were the most prescribed medicines. Mouthwashes, which was either chlorhexidine or povidone iodine mouthwash. 75% of the patients in the ward had been put on mouthwash. 47% were on cetirizine. 28% were put on paracetamol. 14% were on azithromycin and multivitamins. And 5% of the patients had been put on the antibiotic amoxiclav. Clearly from these results, it's quite evident that our patients were suffering from the sorry about that. So from the results, we see that our patients were mostly suffering from mild to moderate disease, and the treatment was majorly symptomatic. The mouthwash was used to decrease the viral load in the saliva and hence reduce the spread of COVID-19. The cetirizine was being used for flu-like symptoms like a running nose. Paracetamol was being used for fever. Multivitamins, especially vitamin C, was being used to boost immune response to viral agents. And for the antibiotics, we can move to the next slide. So 29 patients out of the 192 had been put on antibiotics. Around 60% were on monotherapy, 14% were on amoxiclav 1 gram, whereas 52% were on azithromycin 500 mg. Then 35% were on a combination of amoxiclav and azithromycin. So it's good to note that the antibiotics were not being used to treat the viral infection, but rather the concurrent bacterial infections. And I think the reason why azithromycin was used more than the other antibiotics was because it has been previously used as an adjunctive therapy to prevent severe respiratory tract infections in patients with viral infections. And then also the combination was being used to treat pneumonia that resulted from the virus. Next. So other medicines used, even though not to a very large extent, was protein pump inhibitors like omeprazole. These were being used to treat ulcers, which could have been a pre-existing condition or maybe ulcers brought on by stress from the disease. Other analgesics that were being used included betapine, Zulu-MR, and ibuprofen for the treatment of muscle aches and generalized body pain. For hydration, our doctors put the patients on normal saline, Ringer's lactate, dextrose 50% and 5%. Other antibiotics used were ceftriaxone, cotrimoxazole trimethoprim, and levofloxacin. For the patients who had breathing problems, they were put on salbutamol inhalers. And finally, for patients who had dry cough, were also given cough syrups. So now looking next to the repurposed medicines. Currently, there is no approved medicines for the use of COVID-19, and these medicines under repurposed medicines are being used based on clinical experience gained from treating other diseases. So Pharmacy and Poisons Board has issued an emergency and compassionate use authorization for some drugs to be repurposed in the treatment of COVID-19 patients. So some of the repurposed medicines that were used includes the antimalarial drug, hydroxychloroquine. You remember that it was included in the Solidarity trial. However, the FDA rescinded its emergency use authorization due to no efficacy to the virus, as well as concerns about its cardiovascular safety. Some antiviral agents like favipiravir and remdesivir were used as well. They've, according to several studies, they've shown promising therapeutic effects in the studies. But formerly, remdesivir is used for Ebola virus, while favipiravir is used for avian flu influenza. When it came to corticosteroids, it's thought that corticosteroids help patients to recover quicker, especially for patients with advanced COVID-19 disease, the ones who are experiencing acute respiratory distress syndrome and cytokine storm. At KUTRH, we use dexamethasone for that purpose. Then lastly, there's convalescent plasma. This is where plasma is transfused to a patient, plasma from a recovered patient is transfused to a patient, a COVID-19 patient, the aim being to load the patient with antibodies to enable them fight the virus. Currently, KUTRH is conducting a study on the use of convalescent plasma on patients with COVID-19. And it's good to just note that these medicines are being used based on clinicians' judgment, where they weigh the risk and the benefit profile. And of course, consideration is on a case-by-case basis. Our data revealed that some of the comorbidities that were present included hypertension, diabetes, asthma, HIV, and AIDS. So from the data we got, it was not very strong. So it creates a way for more study to be done, especially on identifying the impact of comorbidities on the morbidity and mortality rate of COVID-19. So finally, in conclusion, the data revealed that a treatment protocol needed to be developed, considering the emerging data, so as to harmonize the prescribing patterns. It also revealed that pharmacists can play a role in protocol development, commodity security, medication therapy management, and medication use review. So this study was presented in-house to the clinicians at KUTRH. This led to a protocol being developed and launched, and this aided in harmonizing the treatment, or rather the prescribing patterns of the clinicians. The MUR also strengthened the need to continue commodity security practices to ensure that the medicines needed were continually available to meet protocol requirements. And finally, pharmacists at KUTRH also played a role on continuous pharmacovigilance, especially identifying adverse drug reactions for the repurposed medicines. So the next slide shows the references we used. And finally, I would like to acknowledge the following: the KUTRH Pharmacy Department, with a special mention of Dr. Wanjiru Mburu, Dr. Anita Mushua, Dr. Eric Njao, Dr. Edward Maina, and Dr. Anthony Kamau for their use, for their presence throughout the study and their input and their contribution. I'd also like to acknowledge KUTRH Health Records Department and KUTRH Senior Management for the support throughout the study. Thank you very much.
Thank you, Daktari, for your great presentation. I'm sure a lot of the other participants who are listening in will be able to pick a thing or two on what they can be able to do better in their facilities on matters regarding managing patients with COVID-19. And I really like the fact that you brought out the use of antibiotics in this whole spectrum of managing COVID-19, taking into account we are all stewards of antibiotic stewardship. So I'd also be very keen to follow up on the results that come out of the convalescent plasma study that you mentioned. That would be something that would be very interesting to watch out for. So thank you once again and keep up the good work. It's very impressive to see that pharmacists are doing great things out there, and most of us can pick a thing or two from what you're doing and replicate the same in our facilities. Thank you, Daktari. So now we are going to go into another abstract presentation, and the abstract will be on enzymatic activity and brine shrimp lethality of venom from the large brown spitting cobra, that is Naja Ashei, and its neutralization by Antivenom. The presentation will be done by Dr. Mitchel Okumu. So I'd like to hand you over your presentation, Dr. Okumu. Karibu.
Good morning. Can you hear me?
No.
Yes, we can.
Derek, you're by there, no, Ari.
Yes, we can hear you.
Yes, good morning, colleagues. Thank you, PSK, for the opportunity to contribute to this scientific discourse. My name is Mitchel Okumu. I'm a postgraduate fellow at the Department of Public Health, Pharmacology and Toxicology, University of Nairobi. My co-investigators are Professors Mbaria, Gikunju, Mbudhia, and Doctors Madadi and Ochola, drawn from the University of Nairobi, Moi University, and the Jomo Kenyatta University of Agriculture and Technology. Next slide, please. Now, snake bite is a neglected public health emergency in sub-Saharan Africa, Southeast Asia, and South America. So among not all the snakes are venomous. We have venomous as well as non-venomous snakes. And even within the venomous snakes, you can get a dry bite where the snake can bite you, but no venom is administered. So that is known as a dry bite. And when venom is administered, now that becomes a snake envenomation. So among the venomous species of snakes, we have the vipers, the elapids, and the colubrids. So the colubrids are the sea snakes. And further, we have classification based on how much disability, mortality, and morbidity the snakes cause. So there we have category 1 and category 2. And from a pharmacological and toxicological point of view, these venomous snakes are further categorized into those that are predominantly neurotoxic, those that are predominantly cytotoxic, those that are predominantly hemotoxic, and those that are predominantly myotoxic. But it's important to note that there, in most cases, there's an overlap between these toxicities. Next slide, please. Now, snake venom is a complex cocktail of proteins, some of which we still don't know what they do and what they are. But the four major proteins that are attributed to most of the symptoms or the symptomatology of snake bite are the phospholipases, metalloproteases, and the three-finger toxins. So the phospholipases and metalloproteases are enzymes, while the three-finger toxins are neurotoxins, which act on the central nervous system. And these are the ones that are responsible for respiratory paralysis. Phospholipases A2 and metalloproteases, as I mentioned, are enzymes, and they're hydrolytic in nature. And these are the ones that have been associated with a lot of muscle and tissue damage. And unfortunately, the antivenom that we have is raised from the snakes themselves, from the venom, but they are not able to neutralize the antibodies that are present, or the immunoglobulins that are present in these antivenoms are not able to neutralize these two enzymes. And that is why most of the time when you're bitten by a venomous snake, such as a puff adder or a cobra, you still end up getting amputated. Next slide, please. So this is a case of the muscle damage that I'm talking about. So this was a case of a 13-year-old girl that was bitten in Taita Taveta County. And it's forming part of some of the clinical case reports that we are following up. And you can see on the left side, that is the bite at presentation. And it just appeared as a blister, but it rapidly deteriorated into compartment syndrome, which needed a surgical procedure, which is known as fasciotomy. And that is what you're seeing on the right of your screen. So as I said, snakebite is a neglected emergency, and up to 3 million people are envenomed every year, and close to 140,000 die. And as you can see in the figure, that it's not only some of the other effects that result from snakebite is the sequelae. Next slide. So this morning, I'm going to be talking about the large brown spitting cobra. This is a relatively new species of snake that is thought to be closely related to the black-necked spitting cobra, or the Naja nigricollis, as well as the Mozambique spitting cobra. And it has to be said that this is a spitting cobra. So in addition to biting you, it also has the propensity to propel the venom into your eyes, and that can cause ophthalmolgia. So as I said, the venomous snakes may be categorized into category 1, which are snakes that are highly venomous, cause high mortality, morbidity, and disability. And this particular snake is prevalent in East Africa, particularly Ethiopia, Kenya, Somalia, and Uganda. However, it is also a category 2 snake in Tanzania. And the principal toxins in this particular snake include the neurotoxins, the hemotoxins, and the cytotoxins. So the neurotoxins are the ones that are responsible for flaccid paralysis. And the hemotoxins can work in one of two ways, either by disrupting your blood coagulation mechanism, or by enhancing it. So by enhancing it, it will result in blood clots. And those, when they travel to your brain, you may get a stroke. And when it travels to your heart, you will get cardiac failure. In addition, this particular snake has cytotoxins. And these cytotoxins are the ones that are responsible for muscle damage, as well as cell and tissue damage. The current management of this particular snake actually is antivenom, but most of the people are relying on cross-neutralization with other related species, but nobody has actually done any work. This presentation will be the first work that we've done anywhere in the world. Next slide, please. So as I said, this is the distribution of Naja Ashei, of the large brown spitting cobra. So you can see it is available all throughout Ethiopia, Somalia, Uganda, Kenya, and Tanzania. And it's interesting to note that over the last decade, there's been a lot of interest in this particular snake. And a few studies have unraveled the skull structure, mitochondrial DNA, the composition of the venom. And you'd be interested to note that even the anti-cancer activity is being explored, as well as others like antibacterial properties, especially in light of antimicrobial resistance that is currently a big problem all over the world. However, having said that, there's still a lot of dearth of knowledge with regard to some of the toxins that are present. And not only that, what is crucial is that we still, up until this presentation, did not know whether the commercially available antivenom that we have is effective against this particular species of snake. Next slide. The problem statement is that the enzymatic activity of this snake is not known. And as I mentioned in the background, the enzymes, particularly the phospholipase A2 and the metalloproteases, are the ones that are responsible for local tissue damage, as well as other local effects such as necrosis. The lethal and toxic effects of the venom are also not known from a pharmacological and toxicological point of view. What is most critical is the capacity of commercially available antivenom to neutralize these effects is unknown. Next slide. So the objectives for the current study, one was we were curious to find out what was the protein content in the venom that we are working with, as well as the protein content in 2 commercially available antivenom. Aside from that, we are also interested to find out what exactly is the enzymatic or the snake venom phospholipase A2 activity of this large brown spitting cobra. And further, we also were curious to know what the lethal or toxic effects of the snake were in an animal model, which is the brine shrimp or the Artemia salina. And this is a very good model because it's a model that targets the cytotoxins in particular. And then finally, and most important, was to evaluate the efficacy of 2 commercially available antivenom against the effects that we had identified in the second and third objectives. Next slide. So before we commenced this study, we got ethical approval from the Biosafety Animal Care and Use Committee of the University of Nairobi, and the reference number is provided. We also got approval from the Kenya Wildlife Service because remember, these are wild animals and they're under the jurisdiction of Kenya Wildlife Service. So we were able to get this through Biokin Snake Farm. Next slide, which I will talk about next. Yes, so the source of the snakes and extraction of venom. So we obtained our samples from Biokin Snake Farm in Watamu, Malindi, and that is the first image you're seeing. Then on your bottom left, that is the large brown spitting cobra while it is being milked. So what you're seeing is the glass sheath where the snake is directed to bite. So what happens is that the snake is fasted overnight, so it becomes very agitated. So when you handle it, it's always looking for something to bite. So when it bites into that sheath, the venom just is released from the venom glands. And what you're seeing is now the pipetting, because as you're removing the venom, the fangs from the sheath, some of the venom remains on the surface of the sheath. So you have to pipette that. So that is what you're seeing Njeri of Biokin Snake Farm doing. So she's pipetting all the venom back into the glass because, you know, it's very, very valuable. Even that small amount is enough to kill a lot of mice and even humans. Then what you're seeing on your extreme bottom right is now the pure venom, which is Naja Ashei. And it is from here that we now subject it to freeze drying because we can't use it in that form. So once we do freeze drying, we get a powder, and that is what we reconstitute here at the laboratory using phosphate buffered saline. Next slide, please. So a bit of information about the samples. So the reference number, the species name was Naja Ashei, or the common name, the large brown spitting cobra. So we had 3 adult snakes, 2 females and 1 male. And then they were captured in Watamu and Kilifi. So other materials that we used, 2 commercially available antivenoms, Then we used bovine serum albumin for protein estimation, and we're using the Lorry's method. Then we used brine shrimp eggs, and these ones we hatch them here at the lab. So they're the animal model that we're testing because, as I said, it's a very good model for evaluating cytotoxicity. The challenge that we have with snake venom research is that it's not the kind of thing that you can have clinical trials, because I don't think there's anyone who will willingly volunteer to be a guinea pig for something that is so lethal. So additionally, we are using agarose and egg yolk. So what you're basically doing is developing a protein substrate. Next slide, please. What you're seeing is protein content estimation. So this is, we used the bovine serum albumin, as I've said. It's a standard protein. So what we're basically doing is making serial dilutions of the bovine serum albumin, and then using spectroscopic methods to find the absorbance values, and then preparing our samples, that is the venom as well as the antivenom, based on the same way that we prepared the bovine serum albumin, then reading off the absorbance values from spectroscopy and deducting the protein concentration. So based on that, we were able to identify that Naja Ashei venom, the protein content was much, much larger than for both the commercial antivenoms that we have in the market presently. Next slide. So as I said, snake venom research is limited by the research that we can be able to do, because most of the time we rely on clinical case reports, and now we, in attempt to mitigate that, we try and run simulations in the lab. So what you are seeing before you, this is an agarose egg yolk substrate media model, where we have made, we've prepared the media. So the media is rich in protein. And what we are targeting is the snake venom phospholipase A2, which acts on the phospholipids in that particular media. So we make 3 wells, as you can see, because in toxicological experiments or pharmacological experiments, we need to have multiples, or in this case, we are using triplicate. So we developed wells on the plate. Then we put venom, aliquots of venom, very small amounts in those wells. Then we incubated it at 37 degrees centigrade to mimic the body temperature. And with that, you can see the clear zones of lysis. So that tells you that the venom was spreading out, and it was breaking down the protein as it spread out. And those are the zones that it created. So what we did was to measure the zone of lysis, similar to how you do it with the antimicrobial discs. So that zone of lysis corresponds to a different dose. So it's basically dose dependent, but I'll get to that in a moment. So we used different concentrations from 0.5 micrograms. That tells you how devastating this venom is. We used 0.5 to 22.5 micrograms per ml. And from that, we only took 10 microliters. So you can see this is the effect of 10 microliters of venom. And you know, when a snake bites you, there's no regulation on how much venom is injected into your body. So we developed, we used regression analysis so that we could make sense of the data. And we came up with a value that we are now going to use in our neutralization assays. So that value was 0.77 micrograms per ml. Next slide, please. So this is some of the data. And it's quite interesting because we did analysis of variance. And once we did analysis of variance, we followed that up with a Bonferroni post hoc test, because from the ANOVA, we could see that there were differences. So the Bonferroni post hoc test was the one that was going to tell us where the differences are. So basically, as I said, we did a concentration from from 0.50 is the phosphate buffer saline, because you have to run a control in any pharmacological experiment. So we ran the concentrations from 0.5 to 22.5. We did a log concentration for each of them. Then remember I talked about using a digital vernier caliper to measure the zones of lysis. And these are the values that we got. As you can see, as you increase the dose, you can see there's an increase in the diameter of the lysis. But that does not tell the whole story. Once we did the ANOVA and post-hoc analysis, we are able to pick out that really between 0.5 and 8 micrograms per ml, there's really no difference in the effect. You might see that the percentages are different, but the software is telling you that there's no difference. Then when you come at the intermediate dose between 10 and 15, between 10 and 12.5, you can see also there's no difference. Then at higher doses again, from 15 to 22.5, there's no difference. So basically what it is saying is that all the venom doses have some effect that could potentially be devastating. Next slide. So once we identified the snake venom phospholipase A2 activity, now we proceeded to identify the cytotoxins in this particular snake. So what we did is that we hatched the eggs, the brine shrimp eggs that I was telling you about. And once we hatch them, then we are collecting them in sample vials. So these are actually very small organisms, but they're very important with regard to evaluating cytotoxicity. So we place them in these sample vials, and we are evaluating different concentrations. And because the organisms are very small, you have to look at them through a magnifying glass. That's what you're seeing in the second image. Then after doing that, we have to record them in a chart. So we use different concentrations. And usually if you look at literature, most people are very quick to just report the 24-hour LC50, because that is the parameter that comes out, the lethal concentration that kills 50%. That's what we are all after. But with venoms, it's a bit different, because in addition to doing this Naja Ashei, I've also been working on puff adder, black mamba and green mamba, as well as other spitting and non-spitting cobras. And we identified that there's quite a variation. So I played around with the numbers, and we decided to do an extended study up to 72 hours, so that we could also capture delayed cytotoxicity, as in the case with puff adder, because puff adder is very slow off the blocks, but with time it gets very devastating. So we did cytotoxicity evaluation of venom and antivenom using the brine shrimp model. So the basis of doing for antivenom is because antivenom is also associated with adverse effects in humans, such as urticaria, angioedema, anaphylactic shock, and the like. So we are curious to also find that out in this model. So as is true with any pharmacological experiment, we needed a control. So in this case, the control is vincristine sulfate, which is a known cytotoxic agent. So we did LC50 for the venom, as well as vincristine sulfate, as well as for the antivenoms. Next slide, please. So these were our results. And you can't make sense of the data unless you use a criteria to be able to rationalize what the data means. So that rationalization, we used the Meyer's toxicity index and the Clarkson's toxicity index. So you can see the first column or the first row is vincristine sulfate. You can see it's highly cytotoxic at 171.83. And as the days go by, it just gets more cytotoxic. And at 72 hours, all of the brine shrimp are basically dead. Then when we evaluated antivenom 1, we could identify that it was safe. The same for antivenom 2. So we can say without a doubt that these antivenoms are safe for use. Then for the large brown spitting cobra, this got very interesting. You can see at first, at 24-hour LC50, the cytotoxic potential is quite significant, more than even vincristine. As in, the lower the LC50, the more potent this particular agent is. But after 48 and 72 hours, you can see now vincristine sulfate is much, much more potent. than this. But that really tells you that these are potential remedies even in the future for cancer medication and others. But the only downside is we need to find a way of having it to be targeted so that it doesn't kill all the cells and just kills the cancerous cells. So probably that is research for the future. The next slide. So once we did that, now we wanted to do neutralization. So we have already identified the protein concentration. We have identified the snake venom phospholipase A2, and we have come up with valuable parameters. And we've done now the cytotoxicity evaluation. Now we know the LC50 value. So in evaluation of neutralization capacity, we had to identify, like for instance, in the cytotoxic model, we had to identify what you're interested in, or the two antivenoms, and trying to evaluate what that means. So the first picture you're seeing is now the in vitro test that we did for evaluating the snake venom phospholipase A2 neutralization capacity of the antivenoms. And basically we are using ELISA. So what you can see are the wells that we are using. And as I said, now we are using an egg yolk suspension. So what we are doing is putting venom plus antivenom, incubating that at 37 degrees, then adding the substrate, which is the egg yolk suspension. So what will happen is if the antivenom is good, then the turbidity will not decrease. But if it is not working, then the turbidity will go down. And sometimes when you look at it at face value, especially for the Cobras, you can actually see the distinction. But with the PAFADA, you might not see it. And you need spectroscopic techniques through the ELISA to be able to tell the absorbance values and then calculate the inhibition from there. So that's what you're seeing on the left. Then on the right is now the setup for the cytotoxicity neutralization, where we are incubating the venom as well as the antivenoms in an incubator at 37 degrees, then adding it to the brine shrimp and then evaluating after 24 hours. So basically we are converting the mortalities into probits, then doing a probit regression analysis to evaluate the neutralization capacity on the cytotoxicity. The same is true for neutralization of the snake venom phospholipase A2 activity. And these were our findings. We found that 1 ml of antivenom 1 neutralized only 0.08 micrograms. So what that is telling you is that you need so much of antivenom to neutralize this particular toxin, which is not economically feasible, considering that a vial of antivenom in a government hospital is probably 6,000 shillings. So if you're to be bitten by a venomous snake, you'd need anywhere between 10 to 20 vials. And most of this affects people in rural areas who really cannot afford this. And especially now with the UHC collapsing, it's going to be even more problematic. So additionally, we established that this antivenom 1 was not able, it was totally ineffective in neutralizing the cytotoxicity of Naja Ashei venom. Then for antivenom 2, we realized that it was a bit even weaker than antivenom 1 with regard to the snake venom phospholipase A2. But with regard to cytotoxicity, it was doing quite well. This was about 0.207 milligrams, which is quite realistic from a point of view of the weight of this venom. That's quite a bit of venom. It might look like a small amount, but you need just a little, as I had shown in my previous slides, to cause a lot of damage. Next slide, please. These are my conclusions, or these were the conclusions from this study. Based on the one-way ANOVA analysis that we did and the Bonferroni post-hoc test, we identified that really the snake venom phospholipase A2 activity and the toxicity in general, it remains fairly constant within a narrow range of venom doses. It really doesn't matter whether you're using a low dose, an intermediate dose, or a high dose. The effect that comes out is almost the same. Additionally, we identified that commercially available antivenoms are generally safe, but notwithstanding, they have some limited efficacy in neutralizing some of these key toxins in this venom. And one of the antivenoms was manufactured in Mexico. And this is the one that we identified. Because remember, as I'd said, nobody has ever done any work on this Naja Ashei. Most of the people are relying on the cross-neutralization because it closely resembles Naja nigricollis, or the black-necked spitting cobra, and Naja mozambica, the Mozambique spitting cobra. So we have identified that for sure, the Mexican manufactured antivenom cross-neutralizes this toxic venom, or the toxic venom proteins in Naja Ashei. Our recommendation is that we need more studies on the activities of other toxins. As I said, it's a complex cocktail of proteins, the venom itself. So we need more studies on the activities of other toxins and how potentially antivenom can neutralize this. Next slide. So we have published a paper on this work. So because actually, as I said, I'm working with other snakes as well. I'm working with 2 mambas, the green and black mamba, as well as other spitting and non-spitting cobras, including the vipers such as the puff adder. And because we are the first to do anything on Naja Ashei, we moved with speed to get out from the process it started, but we are happy to report that we are the first to report anything on Naja Ashei, and this is the publication. So hopefully later on, if you need more information, you can refer to it. It was published in BMC Research Notes. Next slide. So I'd like to acknowledge Bioken Snake Farm and the National Research Fund for funding my project. So Bioken Snake Farm are the ones that provided us with the venom samples, and National Research Fund funded the project. Next slide. I wish to thank you, PSK, for the opportunity to contribute to this scientific discourse. And I wish to thank my colleagues for your attentiveness and your time. Thank you very much.
Thank you so much, Dr. Mitchel Okumu. Just sitting and listening into what you are presenting makes us appreciate that you really have a passion for the work that you do. And honestly speaking, if you asked me before anything to do with Naja Ashei, I would tell you I have no idea. But after listening to your presentation, I have keenly noted that there's a lot of potential for pharmacists, especially in the field of managing snake bites and antivenom activity. And you also mentioned something very important that about in your results regarding the economic feasibility of the quantities of the antivenom that were needed. I think that is something really, really important that must be looked into. And I'd really just like to urge upcoming pharmacists to explore this field because it holds a lot of potential, especially in research. And lastly, I noted that you mentioned something on the possibility of anti-cancer activity and antibacterial properties of the venom of the snake that you are, the Naja Ashei. And I hope that more research can be done on the same so that we have that information. Thank you, Daktari. Very, very brilliant presentation, very informative. Thank you for the good work you're doing, and keep it up. Thank you.
Thanks. Thank you very much.
Yes, so I'd now like to take us to our next presentation, another abstract by Dr. Mary Atieno, and the abstract is on substance use and the effectiveness of interventions at an opioid de-addiction clinic in a tertiary hospital in Western Kenya. Karibu, Dr. Mary Atieno, you can take it up from here.
Thank you very much for allowing me to present. I want to present on the subject of substance abuse and effectiveness of interventions at an opioid de-addiction clinic in Western Kenya. So first of all, I want to acknowledge my co-PIs, Dr. Okumu, Mitchel, Dr. Lauren, Molio Koth, Minal, Onono, and Dr. Chola. So all these people participated in the study, which was carried out at Jaramogi Oginga Odinga Teaching and Referral Hospital. Next slide, please. Next slide. Yeah, so all these were drawn from various facilities. Myself, I'm from Maseno University. We had members from Jaramogi, Moi, and University of Nairobi. So as a background information into our study, substance abuse is a problem that we are all aware of. It is the harmful or hazardous use of psychoactive substances, including alcohol and illicit drugs. So globally, this is a public health problem, and it afflicts mainly the age groups of 15 to 64 as per data that is available. So the main drugs which are normally abused or misused include opioids, cannabis, amphetamine type groups. So these drugs are related with a number of mortality and morbidity, and that is why they need to be managed for those who misuse them because of the problems that they cause to the public. We all know that opioid analgesics are used in the management of pain, mainly moderate to severe pain. And this is the positive aspect of their use. But this use has been overshadowed by the potential for abuse. So even as we handle them, we should have this in mind, knowing that as we dispense as pharmacists, there is that potential for abuse, and we should be very careful even as we dispense them. Next slide, please. So substitution therapy is a key approach in the management of opioid drug abuse. And there are a number of options that are used. In the clinic where we did our study, methadone therapy is used, but others also do exist, like the medical heroin-assisted therapy and buprenorphine naloxone therapy. So those ones are available world over for the medication-assisted therapy towards the management of addiction. So methadone substitution therapy was introduced in Kenya in 2014 as part of a policy initiative to prevent HIV transmission among substance abusers. So this is a sponsored program by PEPFAR through CDC and USAID with the implementation support from the University of Maryland, USA. So this is partly what is happening at Jaramogi. So the first phase of this program was implemented in Nairobi and Mombasa, and Kisumu Center was introduced in 2017. Next slide, please. So the MAT clinic at Jaramogi was established in 2017, and it is the only opioid de-addiction clinic in Western Kenya. So why we did this study is because little information is known about substances abused, factors associated with substance abuse among patients attending the clinic, and the effectiveness of the intervention. So we wanted to measure the effectiveness of intervention at the clinic because this was not known. So we felt that understanding the above may have